Yeah. Hello, good evening. Today is our second discussion about abdominal surgery. We will discuss questions, eMRCS, MCQs. Okay, so let's start reading the questions and discuss together about the answer. So start, Dr. Ahmed.
Okay, Dr. Rami. A 40-year-old female is admitted with sudden onset of right iliac fossa pain. She is otherwise well and on examination has some right iliac fossa tenderness with no guarding. She is febrile. Urinary dipstick is normal. Her previous menstrual period 2 weeks ago. Was normal and the pregnancy test is negative. What is the most likely underlying diagnosis? I think this is mid-Schmerz pain, midovulatory pain. The patient is not febrile. He said 2 weeks ago. This is the midovulatory pain.
Exactly.
Not appendicitis. But appendicitis cannot be excluded. The patient need observation.
Okay, exactly. Anyone has any different answer? Okay, exactly. I think we solved this question yesterday. Yes, A. Charlie Yazid. Just a minute, please.
I think we finished half of the question last time.
Okay. Yes, we're back again. I think this is our last question. Okay. So go for next one. Okay, Dr. Idigo, can you start with us?
Let me read. 28-year man presents with direct inguinal hernia. A decision is made to perform an open inguinal repair. Which of the following is the best option for abdominal wall reconstruction in this case? A. Application of the transversalis fascia using PDS only. B. Suture application of the hernia defect with nylon and placement of nylon mesh anterior and oblique. Suture application of the hernia defect using nylon and reinforcement with a suture repair of the abdominal wall. The suture repair of the hernia defect with Prolene and placement of Prolene mesh over the cord structure in the inguinal canal. And lastly, suture repair of the hernia defect using nylon and placement of Prolene mesh to the cord structure. If I have to choose, It's a direct inguinal hernia. Direct inguinal hernia. Open inguinal hernia repair. The best option, I'm thinking of, there will be a mesh repair. I'm not really sure of my answer, but let me go with B, but I'm not sure.
Okay, who has different question, different answer here?
I think it's E.
Why?
Because mesh is putting posterior to the abdominal wall and
Posterior
cord
to the
structure.
cord. Posterior to the cord on the posterior abdominal wall.
Yes.
Exactly, on the fascia transversalis. We just, exactly, Dr. Basharat. Okay, yes. A. Okay. We're just doing the surgery. This is a young male, and we are doing a hernia unilateral, not bilateral. So we discussed before about treatment of hernia or operations for hernia. In child, we do just herniotomy, and in adult, we have two choices. If it is unilateral, so we always go for open hernioplasty with a mesh, and if it is bilateral or recurrent, we go for laparoscopic. Okay, so here we have a male, young age, 28-year-old, and has a direct inguinal hernia, unilateral. So I'm going to do a hernioplasty with a mesh. The mesh we have just B, D, and E. In B, the mesh will be done anterior to the external oblique, and this is wrong. This is the muscle anterior to the cord, and this is what we cut to. We split to repair the hernia. Okay, and it is, we don't put it subcutaneous. The other option is mesh over the cord structures, and this is under the external oblique, and this is also wrong. We just put it posterior to the cord on the posterior abdominal wall, just on the fascia transversalis, and we suture it between the congenital tendon and the inguinal, reflected part of the inguinal ligament. Clear?
Yes.
Yes.
Okay, I know it's difficult for surgeon, but just know it, we just put the mesh just behind the cord. Okay? Next question. Dr. Abu Yazid, تفضل.
17-year-old male is admitted with lower abdominal discomfort. He has been suffering from intermittent right iliac fossa pain for past few months. His past medical history include negative colonoscope, gastroscopy for iron deficiency anemia. The pain is worsened after meals. Inflammatory markers are normal. What's the most likely cause? Appendicitis, Crohn's disease, peptic ulcer disease, Meckel diverticulum, and irritable bowel syndrome. It's D, Meckel's diverticulum.
Exactly. What's your keyword here?
Keyword, colonoscope is negative, iron deficiency anemia, and after meal, pain after meal, because Meckel's diverticulum contain ectopic mucosal gastric mucosa. Sometime.
Exactly. Okay. So the pain is for a long time, for few months. So
yes, and for a long time.
Appendicitis is out of our choices. So we have Crohn's and irritable bowel syndrome. Irritable bowel syndrome doesn't cause pain, least pain, just discomfort. IBS always causes some discomfort, and not in the right iliac fossa. It is cause generalized abdominal discomfort. Peptic ulcer epigastric, it is not right iliac. And so we have Crohn's disease and Meckel's diverticulum. Okay, Crohn's disease inflammatory markers will be high. Crohn's disease inflammatory markers will be high. It is a chronic inflammation of the at least terminal ileum, terminal iliac. So inflammatory markers will be high. And at the same time, here is a patient just feels the pain after meals, and this is can match with diverticulum with ectopic epigastric mucosa. Perfect, Dr. Yazid. Okay.
Okay.
Meckel's diverticulum. Anything not clear? Okay. Next question. Dr. Zaina, are you ready? Yes, are you ready to share with us?
Yes. Are you hearing me?
But your voice is not clear, please.
Okay.
Okay,
Hello?
go for next question, please.
Hello?
Yes, clear. Yeah, that's clear, yeah.
Okay.
Yes, hi, Dr. Zaina.
Which of the following is not a typical feature of irritable bowel syndrome? Change in consistency of stool, abdominal pain relieved with defecation, change in frequency of defecation, abdominal bloating, pain at a single fixed site. I think pain at a single fixed site. Irritable bowel syndrome most common migratory, not at يعني site معين.
Exactly. It's a generalized abdominal discomfort, maybe sometimes associated with pain. And so pain, we just answered it last question. The pain is not in the right iliac or left iliac fossa or something like this. Okay?
Okay.
Next question. Who wants to share?
Let me
Who
share.
wants to share? Raise hand. Okay, go.
A 2-month-old infant is troubled by recurrent colicky abdominal pain and intermittent intestinal obstruction. On imaging, the transverse column is herniated into the thoracic cavity through a midline defect. What is the most likely defect? A Bogdalic hernia.
What do you think? Without reading the answers, what do you think about the defect here?
Yeah, it's diaphragmatic defects, which cause the
Perfect.
herniate into the thoracic cavity.
Which is here is the diaphragmatic hernia?
Because there are two types. One is the central and the other is the marginal.
No, I'm talking about the options here.
Diaphragmatic hernia,
Congenital.
congenital, Magagni, and the Bogdalic.
So this is the congenital diaphragmatic hernia we expect, yes?
Yes. Which has Magagni and the Bogdalic. Anyhow. So
Okay.
I think the central is a Bogdalic.
Okay. Why is it central?
Because the biggest and the margin is quite small.
Okay. Morgagni is the right hernia, but we just cleared this yesterday. What's the difference between Bogdalic and Morgagni hernia? Okay. I'll just revise it very fast. We said that Morgagni, just let me write, Morgagni, sorry.
Right and anterior.
Okay, let's say Morgagni, Bogdalic. I just want the most, what will you ask it, because right anterior, but you will not ask about it. Morgagni, G, it is a good hernia. Okay, Bogdalic, B, this is a bad hernia. This is present early after birth, because defect is large, posterior, left, on the left side. As it is bad, so it is on the left side. The good is on the right side and small, and present after birth by 2-3 months, because it has a small defect, so it's not very clear. Please, anyone is writing, please close his editing, please, or just make back for what he did. Oh, so Morgagni is small and has small hernia, and so it is presented late after 2-3 months, and also there is no respiratory problems with Morgagni, just some sort of insane obstruction. But in Bogdalic hernia, the main complaint after birth, like respiratory compromise or respiratory distress, as there is hypoplasia of the ipsilateral side of the defect. As the defect is large, so a big part of the abdominal viscera is herniated, so that will make respiratory distress. Respiratory distress to make the child suffering from respiratory complications immediately after birth. But Morgagni is good hernia, small on the right, and through Morgagni foramen, and just presented late after birth by 2-3 months with little complications. Is it clear?
Yes, thank you.
That's more easy to remember. Anyone did use his pen, please make back. Just open your edit again and make back. Okay, just okay. Next question. Who's ready? Dr. Mariam, Dr. Sarah, want to share with us? Dr. Sarah. Okay, Dr. Ahmed Aweda again, please start with us.
Okay. A 56 years old lady is admitted with colic abdominal pain. Plain X-ray is performed. Which of the following should not show air fluid level in plain abdominal film? Stomach. I think the cecum. Maybe.
Has different answer.
Yes, ascending colon.
Dr. Descending colon. Or Dr. Zaina, what do you think? You're a surgeon.
Descending.
Descending.
Stomach
Okay.
can do.
Yes.
I think all.
Stomach can do.
Stomach can do jejunum, ileum.
Okay.
All can do.
Okay. I just want you to just put one. This is a fluid level, yeah? Fluid level. Where we can find here a fluidy content. Stomach. Yes. Jejunum.
Yes, stomach.
Yes.
Yes.
Ileum. Yes. Cecum also contents coming from
yes.
the ileum is at least fluidy. The only place that we can't find
colon.
a fluid, yes, exactly. Descending colon has most contents are hard contents, has little fluid, so it is very rare that we can find fluid level, except in some pathological conditions. Okay, so
But
descending
it
colon
can
is the
be,
only
it
place
can be
that
a descending colon also.
it can be. I say it can be in some pathological conditions, but normally it can't. Okay. Next question, Dr. Zaina. Okay, go. Dr. Zaina.
Okay, Dr. Ram, okay. 53
go.
years old man undergoes reversal of loop colostomy. He recovers well and discharged home. He is readmitted 10 days later with symptoms of vomiting and colic abdominal pain. On examination, he has a swelling of the left of the loop colostomy site and is tender. What is the most likely underlying diagnosis? Obstructed incisional hernia.
Yes.
الاوبشنز بقى هيماتوما intra-abdominal adhesions anastomotic leak anastomotic stricture obstructed incisional hernia. يبقى the answer
Exactly.
obstructed.
Yes, most common question, most common problem here that happens after revision of the of a loop colostomy or a colostomy that may happen through the defect, a hernia, and this is incisional hernia, so it can make obstructed incisional hernia. Okay, Dr. Sodib, I'll open the mic for you. You are not, you don't have a mic, Dr. Sodib, so how you can start with us? So you're asking about, are you completing the question later? I can't understand you. Send me in private and I'll try to understand you. Or just open your mic, so connect your mic to Zoom program or to Zoom application, so you can share with us with your mobile, with your mic, okay? So let's continue, Dr. Iduka.
Okay.
Next question, please.
Okay, a 21-year-old woman, 21-year-old woman presents with right iliac fossa pain. She reports some blood-stained vaginal discharge. On examination, she is afebrile and has a pulse rate of 97 beats per minute, normal blood pressure. She has diffuse lower abdominal tenderness. What is the most appropriate course of action? Laparostomy.
What do you think? What do you think about the diagnosis before we think about the action?
21-year-old right iliac fossa pain. Blood-stained vaginal discharge. Examination.
Blood stain.
PID to some extent, but she's afebrile, so blood-stained vagina, but it's a very young lady, so I'm not thinking of anything like a malignancy, nothing like that. Thinking of ectopic also, ectopic for this patient. So,
so what do you think the diagnosis?
So, abdominal ultrasound scan.
Okay, anyone has different answer?
Ectopic is an emergency. I said they want to go straight away, and then, yeah, if it's an ectopic.
So
thinking of B is B, investigated and treatment together. Yeah.
We have to do first abdominal ultrasound to see.
Exactly. Many of you answered E. This is a case of suspected
Maybe
abdominal
ectopic. Suspected.
Mostly ectopic or ruptured ovarian cyst. So
Ruptured
you
ovarian
have
cyst
to.
all come with.
But you will not see any ruptured ovarian cyst in your answer, and we don't have any questions in eMRCS concerning in rupture ovarian cyst. Okay, 2 scenario with vaginal discharge and bleeding. Okay, both of them are right. Iliac pain. One will tell you with vaginal discharge, and will tell you the patient is pregnant cyst is negative. Okay, or beta HCG is unremarkable. So this is, you have 2 answers for this. If he tell you the patient right iliac fossa pain, so this will be PID. Okay, and the patient also have, sorry, the scenario will tell you right hypochondrial pain with vaginal discharge. So the patient will be PID. Okay, and another one will tell you right hypochondrial pain with vaginal discharge, and the patient has PID few weeks ago, and the pain will be perihepatic fibrosis or perihepatic infection from Meckel from PID. So any vaginal discharge, you have 2 answers, even PID or Meckel pain. And in Meckel pain, he will tell you the patient has PID few weeks ago. Okay? But the other scenario is blood-stained vaginal discharge. Just when you close your eyes, choose direct ectopic pregnancy or disturbed ectopic pregnancy. If it is in the answers, what is the diagnosis? What is the action? It will be abdominal and pelvic ultrasound to distinguish between rupture ovarian or ectopic, but it mostly comes with ectopic. So just you'll do abdominal pelvic ultrasound. This is a medical legal issue to have to do before any exploration or laparotomy to do for the patient. Okay. Next question, Dr. Ahmed.
Okay. 56 years old lady presents with large bowel obstruction and abdominal distension. Which of the following confirmatory tests should be performed prior to surgery? Inguinal ultrasound, gastrography, large bowel and obstruction. Gastrography enema to know the size of obstruction. This is the most, yeah.
Gastrography enema. So we don't know abdominal ultrasound. Oh, okay, barium enema. Why not the barium enema?
Patient is diagnosed here, large bowel obstruction.
Okay. MRI. No.
If there is
Inguinal
multiplicity with
ultrasound.
minimal contrast, it will be the most suitable.
Okay, no, he will not push you to more sophisticated investigation. Just be some.
Yes.
Okay. Yes, gastrography enema is the best chance. Any large bowel obstruction, the easiest way to do. You can't make something like any drinking contrast through the CV, because if you did MRI, we always do it in the rectal or anus, what's called subperitoneal or the post-peritoneal covering, the area after the peritoneal reflection in the pelvis and the anal canal. And CT will do always with contrast, and we can't do it here with contrast because of obstruction. The best is gastrography enema, and it is, if there is even perforation or something like this, there will not make any problem. It will be safe, exactly, because it is a water-based contrast, not like barium
Water
enema.
soluble gastrography.
Exactly. So gastrography enema, we'll do it for every large bowel obstruction before we go for surgery or definite diagnosis.
مش عارف اقول له ايه. قلت له لا خلاص حتى نقول له كده احنا اتسرقت 10 وربع ولسه.
اوكي دكتور ابو اليزيد اتفضل.
21-year-old male is admitted with a 3 months history of intermittent right iliac fossa pain. He suffers from episodic diarrhea and has lost 2 kilos in weight. On examination, he has some right iliac fossa tenderness, and the febrile was the most likely cause. I think because weight loss is gonna be IBD.
Yes, and
See?
diarrhea.
Yes, and
Exactly.
diarrhea, sure.
So it is not appendicitis. 3 months history, it is not appendicitis. Very rare to have with
Diarrhea
appendicitis.
not compatible with appendicitis at all.
Sometimes diarrhea, especially if late for few days or week, we have seen many complicated appendicitis with diarrhea, especially if it is retroileal or especially when it is
come at first, at first diarrhea and then constipation. In retroileal, there is diarrhea for irritability and then constipation.
And also we have seen many cases with pelvic abscess coming with only presentation for few days diarrhea preceded by right iliac fossa pain. But here, direct history, don't just talk about sporadics. We are talking about direct history here. So the history here is diarrhea, yes, diarrhea and losing weight and right iliac fossa pain. This is a case of terminal ileitis of Crohn's disease. So it is inflammatory bowel disease, especially the Crohn's disease, because it causes terminal ileitis and gives a picture mimic the pain of appendicitis. And many cases are missed, not missed. Actually, we just discover intraoperative as it is terminal ileitis and not appendicitis. Okay.
Okay.
Next question. Dr. Zaina. Dr. Isra, if ready. Dr. Shi, if ready, just raise hand, please. Dr. Sarah. Okay, go. Dr. Zain, are you ready?
Okay. 78 years old man walking to the bus stop. When he suddenly develops a severe back pain and collapse. On examination, he has a blood pressure of 90/40 and pulse rate of 110. His abdomen is distended and he is obese. Though tender, his abdomen itself is soft. What is the most likely diagnosis? Rupture abdominal aortic aneurysm, perforated peptic ulcer, appendicitis, mesenteric infection, perforated diverticulitis.
Okay.
I think rupture aortic aneurysm.
Okay. Why?
Shock and يعني الداتا كورليت مع كده مع الابدومينال اورتيك انيوريزم الشوك والابدومينال
patient with low back pain,
Abdomen soft,
severe back
so
pain,
it's retroperitoneal.
so back pain, tender abdomen, so tender. This is itself sudden collapse with low blood pressure and tachycardia. So this is hemorrhage or hypovolemic shock, and nothing of the other causes will cause us hypovolemic shock. Perforated peptic ulcer, no. This is not represented as back pain. This is hypovolemic shock, not septic shock. Yes, will cause maybe septic shock, but it's late. But here is sudden collapse. So back pain with abdominal pain, but the abdomen is soft, collapse, hypotension, tachycardia. This is cardinal signs for rupture, aortic aneurysm. And this is one of the main causes of abdominal pain, back pain, abdominal causes of back pain. Okay. I think we discussed this before. Anyone remember other causes of back pain, of abdominal cause?
Pancreatitis.
Pyelonephritis.
Perfect.
Pancreatitis.
Exactly. This
Acute
is the most
pancreatitis.
common. Sometimes renal colic also as well. Renal colic gives back pain. Pancreatitis. Cholecystitis gives right shoulder pain, but is low back pain or back central back pain. Pancreatitis
most
with
common pancreatitis.
Pancreatitis and rupture aortic or enlarging aortic aneurysm. Sometimes it's compressing on the vertebrae and make some osteolytic lesion in the bone, compression on the bone, and also renal colic sometimes give back pain. And this is the main causes of abdominal causes of back pain, because you have a long station history taking in part B about low back pain, and you have in your checklist, you have to ask about symptoms of abdominal aneurysm, you have to ask about symptoms of pancreatitis, you have to ask about symptoms of renal colic in your differential diagnosis. Okay? Next question. Anyone wants to share? Please raise hand. Okay, next one. Who wants to share? Dr. Sarah, you can. You can't. Dr. Dafir.
Okay.
Dr. Dafir. Okay, you can share with us. We start about 1 hour ago. Yeah. Okay, start. Go.
I'll go. For me?
Yes.
Yes. At 24 years old, man presented with a recurrent inguinal hernia on the left side of his abdomen. Newly diagnosed inguinal hernia on the right side. What is the best course of action? Bilateral open lesionistic repair, bilateral open inguinal herniectomy, bilateral laparoscopic inguinal herniectomy, bilateral laparoscopic extraperitoneal repair, bilateral open shouldice. So it is old age, young age, 24 years, and bilateral. So I choose bilateral open lesionistic repair. A.
Anyone has different answer?
Laparoscopic.
Bilateral laparoscopic inguinal.
Oh, yes. Bilateral, yes.
Not totally extraperitoneal, but laparoscopic inguinal.
Yes. Sorry.
Okay, laparoscopic. We have two laparoscopic here. Which one?
Okay.
Repair.
Transabdominal bulboperitoneal, not totally extraperitoneal. Because there will be adhesion. Because there is past history of inguinal hernioplasty. It will be more adhesion in the bulboperitoneal area. So it will be more better with transabdominal bulboperitoneal.
I will choose the bilateral laparoscopic tip repair.
Okay. Tip and tap will not just, it will be a big issue for you because many are not surgeons and will not, but we just checking. We have two laparoscopic, one herniectomy and one tip repair, whatever tip or tap. Okay, tip is total extraperitoneal and tap transabdominal periperitoneal. Okay, so herniectomy is not logic. So we'll go for laparoscopic tip repair, whatever. One side is first time and the other side is recurrent. So he may go maybe an expert surgeon and can he do it? Because this is bilateral laparoscopic hernioplasty. We can just put hernioplasty instead of tip repair. But herniectomy is not logic in adult patients. But we say again, bilateral or recurrent in a young patient, laparoscopic repair. Okay. Unilateral, open.
Open, yes.
Liechtenstein repair. And in child, just herniectomy. Okay.
No, Dr. Rami, please, I need to understand it. This is the last question. How we do tip repair, transabdominal peritoneal.
So
There will be more adhesion. I need to understand it.
Yes. Can I explain for this?
Okay.
Okay. When recurrent hernia, so it is not virgin operation. It is yes. So it is first one. It's open because in the right side we open, and the other it's contralateral. One side recurrence, and the other side it's start hernia. So it is laparoscopic. If the recurrence,
yes, it will be laparoscopic. Yes.
Yes. So
okay, Dr. Duffer, excuse me. He's just asking about what is the difference.
Yes.
Why
he's just asking what is the difference between TAP?
That is the point.
He is asking what is the difference between TAP and TIP.
Yes.
Okay.
Because the first one. Okay. Yes. So continue.
Okay. In TAP, this is transabdominal periperitoneal. You just go for this is skin, muscles, and then the peritoneum. Okay. What you guys just go with your laparoscope inside the abdomen and go to the hernia and make a cut in the peritoneum. Okay. And make a cut in the peritoneum and make it redundant down. And just here, you drag the hernia. You just pull the hernia till it is all here. So you will find this.
Yes, the section sac from pseudosac. Yes.
Okay. Yes, you'll find this shape. So here the peritoneum will fill down. So you'll fill down. So you'll put your mesh and suture this again. So this is transabdominal. Total extraperitoneum.
Yes.
Total extraperitoneum. You just
I will inflate here
with here. You inflate here to separate the peritoneum and just go direct to pull the hernia and put the mesh and go out without opening the peritoneum.
Okay.
Okay.
Yes.
Is it
In
clear?
the tip, there is more adhesion. Yes. In the tip, Basha.
Okay. By the way,
another operation.
Okay. By the way, in both you'll find no adhesion because in the first operation also you open the external oblique and then deliver the cord, and you just ligated the neck of the hernia. So just only a ligation will happen. You didn't touch the peritoneum because you didn't open the posterior abdomen. You didn't open the fascia transversalis. So you will not have adhesions in TAP or TIP.
Yes.
Very little adhesions you'll have. What you did in the peritoneum in the first
in
operation,
the tip, I will find the adhesion also.
Very little adhesion because what you do in open, you just open the skin and you just open the muscle and the external oblique and the delivery of the cord, and you still have the fascia transversalis and the peritoneum you didn't touch. What you did touch, just a small neck, you ligated. So no adhesions you will find inside. Okay.
You know, this operation is need high learning curve, and this is more difficult. Maybe because of this adhesion, I will make any injury to the peritoneum, and I will lose all the field.
We don't want to go deep because this is out of scope of our study. Okay, so we'll move to the next question. We can talk together about the difference on private, Dr. Ahmed. Okay.
Okay,
because here many of them are not surgeons, so they are now just looking and staring. Okay. Okay, just go for next question. Who's ready? Dr. Daffer, take another question. So
Okay.
you just
Which of these? Okay.
just right.
Which of these factors does not increase the risk of abdominal wound dehiscence? Follow the laparotomy. Jaundice, abdominal compartment syndrome, poor control, diabetes mellitus, administration of intravenous steroid, use of the ketamine as an anesthetic agent. I choose not increase risk. So the use of the ketamine anesthesia agent. So it's DE because jaundice
Exactly.
it's cause.
So the question is, all of the following will cause abdominal dehiscence except, okay,
Yes.
so jaundice will cause, compartment syndrome will cause, diabetes, uncontrolled diabetes will cause, administration of intravenous steroid decrease the fibrosis and decrease the healing, it will cause. So use ketamine as an anesthetic agent will not interfere with wound healing.
Okay.
Okay, so next question, Dr. Dr. Ahmed. Okay, sorry, Dr.
Okay.
Ahmed, and then we
6 years
Dr.
old
Ahmed.
child. Okay. 6 years old child present with colic abdominal pain, vomiting, and the passage of red current jelly stone per rectum. On examination, the child has tender abdomen with palpable mass in the right iliac, in the right upper quadrant. Sorry. Imaging show intussusception. Which of the following condition below is the least recognized as a precipitant? Is least recognized as precipitant.
All of the following will cause intussusception except.
Okay. Cystic fibrosis, Meckel, mesenteric cyst, I think, because this is in the mesentery. يعني not the head of intussusceptum. Cystic inflammation in bare patch can cause. Cystic fibrosis can cause. Meckel diverticulum is the head of intussusceptum. Mucosal polyp can cause. Mesenteric cyst, because this is in the mesentery. It will not cause. It's not the head of intussusceptum.
Any cause of intussusception will be something of the wall protruding from the wall from outside or from inside or through the wall. So,
yes.
Pieris patch, cystic fibrosis, Meckel's, and mucosal polyp, all these are lesions attached to the wall of the intestine. So will cause, but mesenteric cyst is away, outside the code, may cause compression, may cause obstruction, but will never cause intussusception. Okay? Mesenteric cyst will not cause intussusception. This is away from, yes, this is away from the wall of the
intestine.
A wall from the intestine, but it is just outside. Can cause another sort of obstruction in the form of IO or intestinal obstruction, compression from outside.
Maybe.
Okay, next question, Dr. Abu Yazid.
Which one of the following is least likely to cause malabsorption? It's E, Hartmann's procedure.
Okay, you are so ready. So, biliary cirrhosis will cause malabsorption.
Yes,
bypass will cause malabsorption.
Will cause
pancreatitis also. Webels also. Hartmann's procedure, yes, exactly. Hartmann procedure is just part in the rectum, and it is has no absorptive function, so it will not cause malabsorption. Okay, next question, Dr. Zaina. دكتور زينة مش معنا. دكتور إيديجو. Anyone wants to share? Just raise hand, please. Dr. Idog. Dr. Talal, are you ready to share?
Yes.
Okay, go.
63
Just you have
years
a noisy
old
background.
man.
That's why I muted
Okay.
you 2 times. Yeah, some noise background sometimes. Yeah. Okay, go.
Okay. 63 years old man presents with 48 hours history of right iliac fossa pain. On examination, he has a low-grade pyrexia and is tender with some voluntary grading in middle right iliac fossa. Some of blood tests are reported. Hemoglobin 81, the WBCs are 13.8, platelets 438. albumin 22, CRB 24. What is the best course of action? A. Undertaking laparotomy, right hemicolectomy, undertaking laparoscopic appendectomy, arrange for CT scan, undertaking an open appendectomy, arrange a colonoscopy. So
what's your diagnosis here? What's your suspicion here? And this will depend on what's your action. This is an old man with right iliac fossa pain. What do you expect the cause? And his hemoglobin, he is anemic, platelet good,
maybe
albumin
maybe cecal tumor.
yes, perfect. Yes, patient
Maybe
is hemoglobin
because the
low,
patient has
hemoglobin.
hernia and has hypoalbuminemia.
Hypoalbuminemia, so I'll
Exactly.
go for laparotomy right hemicolectomy. Okay.
Wow, you are going to do
No.
operation for a patient
CT
without
scan as a
diagnosis.
start.
Where is your
scan.
staging?
CT.
Where is your staging?
okay.
CT staging and confirmation of your diagnosis.
CT
And the
scan
extent
as a start.
maybe the patient is non-operative. Any tumor, you can't go without a CT to make sure where are you going. Is the patient is operable, non-operable? What is the extent of your tumor? What operation you want to go? What incision you want to go? And just a medical legal document with you for the operation. So going to do a CT scan for the abdomen with contrast or with double contrast is important before you go
With
for
IV and animal contrast, yes.
yes,
Okay.
and sometimes oral. Sometimes oral and
contrast,
animal,
yes.
double contrast. Yes, triple.
Double contrast, yes.
Okay, next question, Dr. Daffer.
33 years old lady presented with the jaundice secondary to the bile, to common bile duct stone. Cholecystectomy and the bile duct exploration is performed, and the bile duct close over T-tube. 6 weeks post-operative, a T-tube cholangiogram is performed and show no residual stone. T-tube removed and find hour after removal a small amount of the bile noted in the drain from the T-tube site. What is the best course of action? Awaiting and spontaneous resolution, arrangement for MRCP, arrange for ERCP, return to theater to explore CBD exploration, reinsertion of the T-tube. The await and spontaneous resolution, because it's no stone, it's mean patent and small few moment after long period. So I choose A, wait spontaneous resolution.
Exactly, this is the fibrous tract, the fistula that is forming between the CBD and the skin, and this is normally closed spontaneously as the normal pathway is clear and there is no obstruction and there is no infection. So it is normally closed spontaneously. So what I'll do, I'll just go, it tell you just 5 hours post removal, and this is await spontaneous resolution as there is no distal obstruction. Okay?
Okay.
Next question. Anyone new wants to share or just go back again?
Okay, I'm ready. If there is no volunteer, I'm volunteer.
Dr. Ahmed is turn, and then you,
Okay.
and then Dr. Irritable. Dr. Ahmed, go.
Okay. Which of the following antiemetic drugs targeted to chemoreceptor trigger zone in the area post-trema?
Or your post-trema. The hypothalamus.
I think metoclopramide. I think in the area. No, I don't know really.
Okay, I said it yesterday. I said it yesterday about antiemetics. We said 3 antiemetics yesterday. Dr. Basharat B, yes. Okay, all said yes. Okay, we said yesterday. This is area postrema. This is an area central in the hypothalamus, I think. And we said we have 3 main antiemetics we will face in our exam or in our question solving. One of them, he will ask you, what is antiemetic good for what is the antiemetic good for central relief of nausea and vomiting? So when we said central, ondansetron is the best, okay? And we said which one is good in vacuumized vacuumized stomach or diabetic gastropathy? And we said erythromycin, because erythromycin can work without vagus, okay? And the third one, which one will work on normal stomach with vagus? And sometimes he will tell you the patient has bleeding esophageal varices. So metoclopramide will be the best. What means will be the best? It will have
the first
an antiemetic effect through the vagus, and also it will increase the
esophageal sphincter.
it will increase the lower esophageal sphincter tone, so will help in not distributing more blood through the GIT and decrease the effect or the problem of hepatic encephalopathy as well. Okay, next question. Okay, Dr. Dafur, go.
10 years old girl has a right iliac fossa pain and appendectomy is to perform. What is the best incision for procedure? So it is female, 10 years, paramedial, midline, Kocher, Lance, grade iron. So I choose Lance. It is more cosmetic for female.
Exactly.
Yes.
Okay, so young or child with appendicitis, we have two options, grade iron or Lance, but what is the best incision? He's here asking the best incision.
is Lance.
So it will be Lance incision. Paramedian, no. Midline, no. Kocher incision is for cholecystectomy.
Yes.
So Lance incision is the best cosmetic incision for a young girl. Next question, Dr. Abu Yazid, تفضل.
21-year-old man is admitted with a tenderness mass in right groin, fevers and sweats. He is on multiple medical therapy for HIV infection. On examination, he has swelling in right groin. Hip extension exacerbate the pain. What is the most likely cause? Hip extension exacerbate pain and fever, HIV infection, so it's low, no immunity. P, psoas abscess.
Okay, so groin pain, fever, sweat. So this is an abscess, so it is not septic arthritis. The patient will come with joint pain.
Yes.
Not a tender mass. If it will get septic arthritis, will not make a mass. Infected lymph node will not affect the hip extension. HIV-related lymphadenopathy also the same, will not affect. Femoral hernia will not affect extension. So the only thing will affect the extension is septic arthritis and psoas, and septic arthritis will not cause a mass. So by exclusion, you can say it is psoas abscess. Okay?
Okay.
Next question. Dr. Idugo. Dr. Idog or Idugo.
Yeah, let me
Yeah,
read it.
ready? Okay. Okay.
Which of these following intervention is most likely to reduce the incidence of intra-abdominal adhesions? A peritoneal lavage with citramide following elective right hemicolectomy, use of laparoscopic approach over open surgery, use of tack to coat surgical gloves, performing a noble plication of the small bowel, using staple rather than a handsaw anastomosis to reduce the incidence of intra-abdominal adhesions.
So most likely.
Use of laparoscopic approach over open surgery.
Exactly. More manipulation inside the abdomen was hands with gloves and talc powder, and also some adhesions, and the manipulation causes more adhesion. So use of a laparoscopic approach is the most clear operation, or clear to protect against any internal adhesion. Okay.
Yeah.
Next question, Dr. Zaina. Dr. Zaina, want to share? Okay, no. Okay, Dr. Ahmed again. Go.
Okay. In
Dr.
which of the
Dafar.
following scenario?
Okay.
Yes,
Next
yes.
one, Dr. Dafar. Okay. Okay, Dr. Ahmed, go.
Okay. In which of the following scenario is a mucus fistula most likely to be encountered? Following electrolyte hemicolectomy, لا. Following Ivor Lewis, subtotal colectomy. Following abdominal hernia excision, infectum, following small bowel and incarcerated from within. I think no. I think E. Following small bowel resection and primal anastomosis. No, sorry. In the C, يعني we do terminal ileostomy. يعني in the C. I think C. Emergency subtotal colectomy for severe colitis.
Okay.
I think
so
C.
anyone has different answer? Both one C, Dr. Basharat D. Following
It will be
abdominal
encapsulated.
peritoneal, abdominal perineal excision of colon and rectum. For rectal cancer, we do there is nothing mucus fistula.
Terminal,
terminal colostomy.
Yes.
Okay.
Terminal.
Following elective right hemicolectomy,
in subtotal
we don't.
colostomy.
Ileocolic anastomosis, we don't have. Evoluloid is something like in the thoracoabdominal. We don't do a mucus fistula. Okay. The last
Dr.
one is
Rami,
primary anastomosis. Yes.
can you explain
Yes, exactly.
the pathogenesis of mucus fistula?
Okay. You just want what is the operation of mucus fistula? You just go for when you do hemicolectomy or colectomy, subtotal colectomy. You have, okay, just will draw it. This is the colon, 6 point. And this is the ileum, okay? Subtotal colectomy. Okay, we are removing most of the colon, leaving part of sigmoid or the rectum and something like this, and we are removing all this. Okay. After we remove, you here have to take 10 centimeter also of the ileum. We have two options. The first one, you just want to take the ileum and connect it with the rectum. So what's called ileorectal or ileoanal anastomosis. And another one, if we can't do it as a primary, we can close the terminal part of the rectum and make it what's called Hartmann's. Or if we can't close this for any cause, like we have a severe colitis and severe infection, and it is difficult to make suturing here, okay? So what we do, we just go for the abdominal wall. Okay, now we have severe infection, so we can't make suturing, even Hartmann or ileorectal or ileoanal anastomosis. We can't do it because of severe infection. So we'll go with the ileum, with what is called terminal ileitis, terminal ileostomy, sorry. And also will extrudize the rectum like mucus fistula. So I can see it. So in the anterior abdominal wall, on the surface of the abdomen, you will find two opening, one from where the food and fecal matter pass, and the other one just secreting some mucus secreted by the wall of the rectum or the inner canal and rectum to go direct for the exterior. So this is what's called the mucus fistula. Okay, mucus fistula we removed, and we couldn't.
Yes.
We can't close it for any cause, mostly through infection or mostly for severe infection. Happens with diverticulitis, colitis, any abdominal severe trauma with lacerated terminal rectum or the rectum and the colon. Sometimes we can't close, we just make the loop outside the abdomen and suture it to the anterior abdominal wall like a mucus fistula, so I can care about it and make sure it will not rupture or fistula inside the abdomen. That's all about mucus fistula. Okay?
Okay.
Clear for all?
Clear.
Clear.
I know it's sometimes difficult for non-surgeon, but what can we do? Okay. Next question. Whose turn? Dr. Zaina. Oh, Dr.
Hey, Dr.
Daffer?
Yeah,
Okay. Dr. Daffer, go. Dr. Daffer, go.
24 years old, presented with a 10-day history for right side abdominal pain. Prior to this, he was well. On examination, he was low-grade fever and mass palpable in the right iliac fossa. The rest of his abdomen is soft, and the abdominal ultrasound demonstrated a matted bowel loop surround the thick appendix. What is the best course of action? So it is appendicular mass. Arrange laparotomy and the right hemicolectomy. Perform laparoscopic appendicectomy. Perform open appendicectomy. Manage conservative with antibiotic. Arrange for colonoscope. So it is D. Manage conservative with antibiotics, because when fully operated for appendicular mass, it will hurt the bowel and increase the risk of infection and incisional hernia and other items.
Okay, what is this regimen called?
Oshler-Chenier.
Oshner-Chenier. Okay, Oshner-Chenier. Perfect, Oshner-Chenier. This is a conservative treatment for abdominal mass. Okay, abdominal appendicular mass or appendix mass, exactly, appendix mass. So it is Oshner-Chenier conservative treatment. We don't do operation for complicated appendix with mass or complicated gallbladder with mass. We just go for conservative treatment, and we do what is called elective appendectomy after from 3 to 6 months. Okay.
Okay.
Sometimes it happens by process, and we don't need to do appendectomy. We call it interval appendectomy. Okay. Next question, Dr. Zaina.
Okay, 15 months old girl present with a 3-day history of periorbital edema. She is brought to hospital. On examination, she has a facial edema and a tender distended abdomen. Her temperature 39 and her blood pressure 90/45 millimeter. There is clinical evidence of poor peripheral perfusion. What is most likely diagnosis? Sickle cell crisis, intussusception, spontaneous bacterial peritonitis, Henrich-Schönlein purpura, appendicitis.
So this is a young girl. She has periorbital edema in young age. On examination,
it looks like nephrotic syndrome.
Exactly.
Yes.
Tender distended abdomen, temperature 39.
I will choose C, spontaneous bacterial peritonitis.
Okay, this is some information just to put in mind. Some of the side complications that is susceptible for the patient with nephrotic syndrome. He may have, because of low immunity and low resistance, he may have a spontaneous bacterial peritonitis. Where spontaneous bacterial peritonitis you can see. This is out of scope, and you will not have any question like this. Where you can see this problem also.
It's an immune compromised patient.
Very common with
Acidic patient.
Exactly. Hepatic patients.
Yeah, hepatic
We
patient
many-
with ascites.
Hepatic patients with ascites. Sometimes we found spontaneous bacterial peritonitis. It's a very common question. Sometimes happens, and you go for cephalosporins for treatment. Okay. Next question. Or Dr. Talal want to share? Dr. Talal, ready?
Okay, which of the following statement related to breast abdomen is false? Is seen in 1 to 2% of modern laparotomies, is more common in fecal peritonitis. Is this common with mass closure technique is used? When it does occur most common at 15 days. It is similar in incidence regardless of whether one or polydextrin on body used. I'll go with D.
Okay. So when it is most commonly happen?
I think 5 days or 6 days. 5 days.
Almost from five to 7 days. From 5 to 7 days, or the end of the first week after surgery. So this is the right one. Others are all right. More common with fecal peritonitis. Very little seen now in modern laparotomies, and mass closure of the abdomen is the best in decreasing the incidence. Similar in surgeon regards where this proline or polypurine, the same results will give to us. Okay, next question. Doctor, who wants to share, Doctor?
Yes.
Dr. Ahmed, okay.
Okay. 67 years old man is due to undergoable procedure to resect bacterial pancreatic adenocarcinoma. What is the most appropriate surgical incision to address this? Median lateral thoracoabdominal. I think we lower bilateral subcostal. We did Mercedes incision. I don't know what is this. Rooftop, maybe rooftop.
Rooftop, exactly.
Yes,
Perfect.
lower Mercedes incision. That's bilateral subcostal with extended upper.
Yes, okay. This is rooftop, bilateral subcostal or bilateral cochar. Cochar is for cholecystectomy, paramedian or patel or thoracoabdominal. This is not of our scope. Okay.
Mercedes or rooftop, yes.
Yes, rooftop. Okay, next question. Dr. Yazid.
35-year-old woman who is a heavy smoker, has long-standing stool frequency and crampy abdominal pain. A colonoscope is performed, which is macroscopically normal, and pancolonic biopsy are taken. Histological analysis of the biopsy demonstrate a thickened subapical collagen layer together with an increase in lymphocyte of lamina propria. What's the most likely diagnosis? I don't know.
Yes, just it is
Microscopic colitis.
exactly. Even I don't know, and I didn't see this question, by the way, in the last 2 or 3 years recalls. Maybe an old question, but we can go it with
diagnosis by exclusion.
By exclusion. Let's go Crohn's disease.
All the
Sometimes you can see it all the layer.
Yes.
And ulcerative colitis you can see by endoscopy. Pseudomembranous colitis you will see it by endoscopy, and the picture will be involving the mucosa and pus, and it will be more neutrophils, not lymphocytes. Irritable bowel syndrome, you will find normal histopathology. So the only thing is microscopic colitis by exclusion. So this one of the question you'll go for by exclusion. And it's very rare question, but you just put in mind. It may come again, maybe, but I didn't see really for a long time. Okay, next question, Dr. Duffer.
A 45 years old man, recurrent abdominal pain. Apart from series of investigation, he undergoes a CT scan and is demonstrated hernia lateral to the rectal muscles at the level of the adequate line. What is the type of the hernia? This is the letter Richter Spigelian Morgagni incisional. So it is Spigelian, the side between the internal oblique and external oblique, lateral to the rectus, at the site of the periphery of this artery.
Exactly. This is Spigelian or splenian hernia. So this is the hernia of the rectus sheath or the hernia of the arcuate line. Okay.
Yeah.
What is Litter's hernia?
Litter's hernia, presence of the Meckel.
Little hernia, Meckel diverticulum.
Yes.
Okay. What's Richter's hernia?
Part of an
Part of the circumference of the abdominal wall herniated.
Antimesenteric herniation, antimesenteric wall herniated.
Not sure to be anti-mesenteric, just part of the wall of the viscous. Maybe stomach, maybe colon,
part
maybe,
of the circumference.
Yes, maybe colon, maybe bladder. Part of the circumference of the organ
just
will be
just to
part of the circumference.
Part of the retroperitoneal. It is a sliding hernia. As of
sorry. Yes. I'm just talking. Yes, sliding hernia, but
Richter,
I'm just talking.
I will send the picture.
Yes, I know. It's but if it is part of the stomach wall.
Yes, antimesenteric. So it is the stomach with the Richter. It is away because there is no. We cannot find the stomach in the inguinal region. But
yes, I.
But can we find the small bowel or large bowel? Yes.
Okay, so it is part of the rectum. What is antimesenteric or anything? Just, but what is Morgagni hernia?
Morgagni hernia is the right side diaphragmatic hernia.
Congenital diaphragmatic hernia. Yeah. Okay, next question. Dr. Zaina.
Okay. 40-year-old man present with long-standing inguinal hernia. On examination, he has a small direct inguinal hernia. He inquires as to the risk of strangulation over the next 12 months should he decide not to undergo surgery. Which of the following most closely matches the likely risk of strangulation over the next 12 months? 50%, 40, 25, 15, less than 5%. Direct inguinal hernia has
3%.
less risk for strangulation, less than 5%.
Exactly. I don't know the answer exactly with this question, but when I went for this question, it's wide neck. It is very, very rare. I hadn't seen any obstructed in the direct hernia before. So it should be less than 5%. It will be more the most suitable answer for this question. Okay, so it is 3%. Even if I don't know, but I know that I haven't seen before, so 5% will be the logic answer. Okay, next again, Dr. Idugo, are you ready?
Oh, yes.
Not here. Yes, okay, go.
An 18-year-old female present to the emergency department with sudden onset, sharp, tearing pelvic pain associated with small amount of vaginal bleeding. She also has pain. On examination, she is hypotensive, tachycardic, and has marked cervical excitation, which is the most likely explanation.
It's clear.
I'll say rupture ectopic. But there's A, degenerative fibroid, C, adnesia torsion, C, rupture ectopic, E, rupture appendicitis, and E, endometriosis.
Okay. We said before one of the history of pelvic pain or right iliac fossa pain was vaginal bleeding, and he didn't mention that beta HCG is unremarkable or pregnancy test is negative, so the patient is rupture ectopic if the patient is in the childbearing period or fertile, so she is ectopic until proved otherwise. Even in your practical work, any young patient with right iliac fossa or pelvic pain, before doing, even if you diagnose it as acute appendicitis, you have to do ultrasound and pregnancy test for all fertile females before going for operation for appendicitis. Many ectopic will give you the picture of appendicitis, even not ruptured, just a small mass, and I did see it many times, small mass without rupture, without vaginal bleeding, right iliac fossa pain, and female, and by ultrasound maybe there is a mass, and even the radiologist can tell you, I can see an appendicular mass or appendix mass, and you open, you just find a swelling in the tubes, in the fallopian tubes. So any female in childbearing period or fertile female, young, and he tell you vaginal bleeding, and he didn't mention anything about mid-cyclic, or he didn't mention about BCG or ectopic or pregnancy test, so it is rupture ectopic. Okay?
Okay.
Yes.
And the other question, he will tell you, what will you do? Abdominal pelvic ultrasound.
Yes.
This, yani one time he asked about the investigation and the other time asked about the diagnosis, and both are the same scenario. Okay, next question, Abu Yazid. Dr. Abu Yazid, تفضل.
60-year-old woman has fully recovered from attack of pancreatitis. Over the following 12 months, she developed epigastric discomforts. Upper GI endoscope show gastric varices only. An abdominal CT scan demonstrate a splenic vein thrombosis. What's the treatment of choice? It's A, splenectomy.
Yeah, exactly. Splenic vein thrombosis. Treatment is splenectomy. Okay?
Okay.
This is the best treatment for splenic vein thrombosis, because we fear of portal hypertension and bleeding esophageal varices, so we'll go for this. Okay, next question, Dr. Zaina, go again.
Okay, which of the following is commonest cause of acute abdominal pain in acute unselected surgical take? Non-specific abdominal pain, biliary colic, acute appendicitis, urethric colic, pancreatitis. أنا مش فاهمة السؤال أصلا يعني.
Most cause of acute surgical abdominal pain. You are working in ER and you have just remember days of hospital working, and you have about 15 to 20 patients per day coming with abdominal pain, and you go to see them, and how many will you know what is the pain exactly? Sometimes you know it is appendicitis, sometimes it's biliary colic, and I think more than half you will find you can't reach a diagnosis of the patient. All investigations are free, ultrasound is free. Sorry? Non-specific abdominal pain is the most common of, yeah. Okay. This is the psychic patient or something like this. We found in ER, and you do all the investigation, urine analysis, blood test, and ultrasound, all are clear. And you say the patient, it may be some stomach colic, just go home and you'll be fine. And this is what we say, non-specific abdominal pain. Okay.
What take referring to? Take.
The surgical take, the surgical shift. You have a surgical shift.
Okay.
Okay. You just or it doesn't make a difference in the just you have many cases now in surgery, and you have many abdominal pain, and you want to know what is the diagnosis for all the 20 cases will come for you. You'll find about 8 to 10 cases you don't know what is the diagnosis, and we just say it is abdominal colic or intestinal colic. Some colic, you go home, take this medication, and if it has happened again, just come back in the morning. Yes, that's what we do in the ER. Okay, next question, Dr. Dafer.
Okay. In which of the condition list below choline sign most likely to be seen? Rupture,
yes. Where will you see colon sign?
Intra-abdominal.
And what is colon sign?
Colon sign, it is the discoloration on the pre-umbilical discoloration. It's occur in the
perfect. Where you see it?
It's occur in the pancreatitis or any other.
Generally.
Yes, in the intra-abdominal.
Intraperitoneal hemorrhage.
Intraperitoneal.
Intraperitoneal hemorrhage. Intraperitoneal hemorrhage. Just go for the next few choices.
Yes, it's ectopic, rupture ectopic pregnancy, appendicitis, intestinal malrotation, perforated peptic ulcer, incarcerated femoral hernia, so rupture ectopic pregnancy.
Okay, without reading the rest of the answer, so we know colon sign. And what is the other sign that we see in the retroperitoneal hemorrhage?
In the retro, great turn sign.
Great Turner. Okay, Great Turner. We see it in the flanks, retroperitoneal hemorrhage, like hemorrhagic pancreatitis, sometimes leaking abdominal aortic aneurysm. You can see Great Turner sign. Okay, this is in the flank, ecchymosis, and this is a periumbilical ecchymosis. Okay, next question. Dr. Talal, are you ready?
Okay, 72 years old obese man undergoes an emergency repair of ruptured abdominal aortic aneurysm. The wound is closed with an only proline mesh targeting the closure. Post-operatively, he is taken to intensive care unit. Following the 24 hours of nasogastric aspiration increase, his urine output falls, and he has metabolic acidosis. What's the most likely underlying cause? Chronic ischemia, abdominal compartment syndrome, peritonitis, reactionary hemorrhage, and aortoduodenal fistula. I'll go with abdominal compartment syndrome. B. Okay.
Sorry, I forgot to unmute. Next question, who? Dr. Idogo?
What's the commonest site in the abdomen for fluid to collect following a appendix? A, pelvis, B, hepatorenal pouch, between small bowel, right iliac fossa, and lesser sac.
What do you think?
Yeah. The pelvic pouch.
The pelvic?
No, A.
Choose A.
Yeah.
Exactly. The pelvis is one of the commonest area for infections or leaking infection from the lower abdomen in standing patient or any semi-sitting patient. That's why we always prefer post-operative to make the patient semi-sitting, so any collection will be collected in the pelvis. The other place where it is commonly to collect in a patient, supine patient, is
Paracolic.
Lesser sac.
most common.
السوباين hepatorenal.
Hepatorenal. In supine patient, hepatorenal or Morrison
السوباين
pouch.
hepatorenal.
Yes,
Okay.
so in semi-sitting or standing patient, the pelvis, and supine patient, hepatorenal pouch. That's why any collection we are doing fast.
Okay.
For trauma, we just look for the hepatorenal and pelvis and the epigastric place, like for the heart, and this is the most common places we look in any traumatic patient. Okay, next question. Dr. Ahmed.
Okay.
Dr. Ahmed Awida.
Yes, okay. 56 years old man undergo difficult splenectomy and is left with pancreatic fistula. There is ongoing problem with very high fistula output. Which of the following agent may be administered to reduce the fistula output? We will give sandostatin. We'll give
exactly.
Yes, octreotide.
Octreotide is a synthetic sandostatin, and it's very common to use in any fistula to
sandostatin
decrease
is reduce all the secretions, pancreatic.
To reduce all alimentary secretions as well will be decreased by sandostatin or synthetic octreotide.
Yeah.
Last question. Okay, Dr. Dafri, because he joined late.
Okay. A 52 years old obese lady reported a painless mass in her groin, in the groin area. Mass is noted on the cuff. It is below and lateral to the pubic tubercle. What is the most likely causes? So it is a femoral hernia.
Exactly. The answer is easy. So we have two questions about this. One question, he said the patient has a pain in the groin area and flexing the hip, and in examination you just find some pain and has abdominal obstruction. What's your and she was 78 or 87-year-old. So what's your differential diagnosis? 78 old age patient with pain on the groin area and flexing her side and picture of abdominal obstruction. What's your differential diagnosis?
Femoral hernia, obturator.
Obturator hernia. You have obturator hernia. Okay, obturator hernia. No, volvulus will not cause groin pain. Because irritation of the obturator nerve, you will have a pain in the groin.
Radiating to knee.
Radiating to knee. Yes, exactly. Groin pain radiating to knee. Okay. The other scenario, you have a groin mass. So we have two scenarios: groin pain, radiating to knee with picture of abdominal obstruction and sometimes flexing her knee, and old age. The other one is old age with mass in the groin area and picture of abdominal obstruction. And this is the third one with mass but younger age, and the mass is not obstruct, just has impulse on cuff. So this is a femoral hernia. So femoral hernia will give us a mass. Obturator hernia will give us a pain at the groin radiating to the knee. And that the two scenarios we have for this. Thank you. I'll close the recording, and if anyone wants to discuss or ask about anything, can ask me.